Good morning, everyone. I'm Dr. Mike Arnold of Children's Hospital Colorado and the University of Colorado on the Anschutz Medical Campus. And I'm live on Instagram this morning to continue talking about pediatric pathology basics. And today we're going to talk about appendicitis. What is it? What does it look like under the microscope? And I'm also going to have some bonus cases to show you some things that we might be surprised by when we find in the appendix. So let's look at some cases. Let's start out by, what I want to start with is, what does a normal appendix look like? And I'm going to talk a little bit about how we gross it as well. So this is what a normal appendix looks like under the microscope. And you'll see we've got a couple sections here. We have a cross-section, a longitudinal cross-section of the tip. And we have a couple of cross-sections of the length of the appendix. And then we have this base margin. So the appendix is a small tubular structure that's attached to the proximal colon. And so when it comes out, it's this blind ending pouch that's probably about the size of your pinky. And when we gross it, we're going to put ink, this black ink that you can see here, on the base margin. We'll talk about why that's important later. And then we're going to take some sections to represent cross sections along the length of it. And then the very tip of it, we're going to remove about a centimeter or so and bisect that so that we can see the lumen in both pieces of this tip. And let's talk for a second about the histology of the normal appendix. What's normally here? Because this is going to help us understand what abnormal looks like. So the mucosa here looks like normal colonic mucosa. You have columnar epithelial cells, you have occasional goblet cells, and you have some lymphocytes in the lamina propria. But you'll probably also notice that there's a lot of lymphoid tissue here. There's a lot of germinal centers, and it kind of looks a little bit like the lymphoid tissue you might see in the terminal ileum of a kid. And in kids, they have a lot of lymphoid tissue in their intestine, particularly in the terminal ileum and the appendix. And you don't want to get concerned about this. It's not a problem. It's normal. As an attending I had during training once said, kids' immune systems are still meeting the world. So it's normal for their immune system to be excited about meeting the world and have a lot of this reactive germinal centers and lymphoid tissue in their GI biopsies. So this is not anything to worry about. It's totally normal, and you can see these are nicely polarized germinal centers with polarized mantle zones, all the things you'd want to see in normal lymphoid tissue. As we go out further here, we see that the submucosa, there's a little layer, it's really hard to find in a lot of places, a little layer of muscularis mucosae, and then there's the submucosa where you see fibrous tissue, adipocytes, and if you hunt around in here long enough, you'll probably find a ganglion cell. Here's some nerves and vessels, and then you have the muscularis propria that has an inner and an outer layer, and then you'll have subserosal tissue, which is usually adipose and fat, and then the serosal surface. So now that we've got a good sense of what normal looks like, let's talk about appendicitis and why appendices get removed. So if you're familiar with medical terminology, you'll know that anything that ends with an itis is an inflammatory process. And appendicitis is no different. It's inflammation of the appendix. And so what we're looking at here is we're seeing that our normal mucosal architecture is going away. We're seeing these little ulcerations in the mucosa where the architecture is going away, and we're starting to see inflammatory cells. And you can see here there's neutrophils. You can recognize those by their multilobated nuclei. You see some necrosis where you see fragments of nuclei as cells are dying. So there's some mucosal inflammation. Here we also see that there's some inflammation, acute inflammation, neutrophils in the germinal centers as well. And most importantly, to call this appendicitis, we want to make sure we see that inflammation extending into the muscular wall. And so you can see as you look through here, you see neutrophils in the submucosa, and you can see neutrophils percolating through the full thickness of the muscular wall, all the way out into the subserosal tissue, even in this example. So that's what it looks like under the microscope, but how do we get this specimen? Why does it look like this? So when appendicitis happens clinically, patients are going to have abdominal pain. And a lot of times they'll have abdominal pain in a very characteristic location in the abdomen called McBurney's point, where you have pinpoint peritoneal tenderness right over where the appendix is located. And surgeons are going to want to take these out because, of course, if this progresses, it could perforate, patients could get septic, and they could die. So you're going to want to have an appendix removed when you suspect appendicitis, and actually surgeons are going to want to have a rate of negative appendectomies, which is how we got specimens like the normal I started showing you. So surgeons are going to remove appendices with a pretty low threshold because the risk of not intervening is much lower than the risk of not intervening is much higher than the risk of intervening. Laparoscopic procedures are generally pretty safe for most patients. Now, sometimes we will have patients where they do interval appendectomies, and we'll talk a little bit about that later. But you can manage these patients temporarily with appendicitis. Here's a really good example of just sheets of inflammatory cells, neutrophils, histiocytes replacing the mucosa, and then percolating all the way through the muscular wall. So there's a really good example of a nicely developed appendicitis. So what happens if they don't take this out? If this doesn't get detected early for whatever reason and it continues, it's going to start to look like this. So here we see another example of appendicitis. We see the mucosa is effaced by this debris of histiocytes and neutrophils, and you can see there's neutrophils all the way through the wall. And now we're seeing something else. We're seeing this really purple discoloration. Everybody in the chat know what this is? So this purple discoloration is gangrenous necrosis. This is tissue that's dying and liquefying. And you can see it here in the subserosa, you can see it in the muscular wall. And in this example, you can actually see that there's an area of the appendiceal wall that's completely necrotic and broken open. Grossly, this was perforated. So you can see this gangrenous necrosis. You can see the muscle is dead. There's no longer nuclei here in the muscles or the fibrous tissue, and then it just breaks open. So that's what it looks like when it perforates grossly. Earlier than that, you can actually see microscopic perforation. So how do we define a microscopic perforation? If we don't see a perforation of it grossly when we're examining the specimen, we may still see a perforation of it microscopically. So here's another appendicitis where we see acute inflammation and histiocytes replacing the mucosa, and we have neutrophils that are getting all the way through the wall. You can see there's even eosinophils here. Sometimes eosinophils are precursors of neutrophils, neutrophils declaring themselves in appendicitis. But look what happens here. So if you try to follow, let's go back a little bit. If you try to follow the muscular wall here, you can see the muscle fibers, and you can see that there's a lot of inflammatory cells between them. The nuclei of the muscle fibers are these long, round, ovoid nuclei, and the inflammatory cells, lymphocytes, neutrophils, eosinophils, are kind of mixed in between them. And as you follow the fibers, what you'll notice as you come over here is it gets harder to see where they're going. So you can follow this track of fibers right here, and then they stop, right? You see there's a few nuclei of smooth muscle here, and then they go away. There's hemorrhage, there's fibrin, this pink fluffy material, there's histiocytes, these larger cells with round nuclei, and there's a complete path of this pus all the way from the lumen all the way across through where the muscular fibers ought to be to the serosa, and this is a microscopic perforation. You want to distinguish that when you're looking at these specimens. You want to distinguish that from vessels that might be going through the muscular wall like this, and neutrophils that are following those vessels. This is very different because you have a complete interruption of the muscle by this fibrinopurulent exudate. Here's a really good look at it right here. You can see the muscle fibers, and they just disappear into this pus. So this is a microscopic perforation. Now, I mentioned that you can sometimes manage patients with antibiotics. You may not take the appendix out right away. In some patients, they can actually have subclinical bouts of appendicitis before they have the bout of appendicitis that brings them to clinical attention. And you can actually find evidence of previous appendicitis in an appendectomy specimen. We call that fibrous obliteration of the tip. And here's what that looks like under the microscope. So at low power, you see here, here's the base margin with the ink. Here's our cross section, and you can see it's got a nice lumen. It doesn't have much in the way of inflammation in this particular section. But if you look at the tip, instead of having lymphoid tissue and mucosa all the way into the tip, like we saw in our normal example where the lymphoid tissue and mucosa extended nearly to the end of this blind pouch, this contains fibrous tissue, scattered inflammatory cells, collagen, vessels, and adipose. And you can tell this is not a sectioning artifact because when you take the tip and you bisect it and you submit both halves, you should be able to find the mucosa in one half. If you don't, it's because the tip of this appendix, what's inside the muscle, has scarred down. And you can see it's all the way down here that you're starting to see lymphoid tissue, and the mucosa is probably just off this section. So this is fibrous obliteration of the tip. This is evidence that there may have been a previous bout of appendicitis in this patient. So we've talked a little bit about appendicitis and how we want to see neutrophils in the mucosa. We want to see neutrophils throughout into the muscular wall. But what happens when we don't see that? So here's an example of an appendix where the tip looks fairly normal, but you can see there's something sitting on top of the mucosa. You can see this exudate. You can see fibrin, you can see bacteria, you can see neutrophils, histiocytes, kind of sitting on top of the mucosa. And you'll probably find some areas where there's neutrophils that are getting into the epithelium. But in this example, that's really the extent of any inflammatory changes. You see there's some fecal material here. So really minimal changes and just this kind of luminal exudate. So what do we do with this and why is this important? So when we're examining an appendectomy specimen, we're trying to confirm that the patient actually had appendicitis. Because if they didn't, we need to give feedback to the surgeon about what else could be going on that could have caused this patient's symptoms. So in this case, when we've got luminal debris, we got luminal exudate, and we've got mild mucosal inflammation, we're just going to describe that and say that it doesn't meet the histologic criteria for appendicitis, right? Because we only have neutrophils in the mucosa. Now, of course, before we say that to the surgeon, we're going to make sure we go back to the bucket and submit everything so we can examine as much of the muscular wall as possible. But when we see it like this, where we don't see anything in the muscle wall, there's no neutrophils, we're going to say, hey, this is just mucosal inflammation only, and there's a couple things that could mean. It could mean that the patient has something going on in the colon, like an infection, like colitis, that's just kind of backwashing into the appendix. Remember I said that the appendix is a blind ending tube that's attached to the proximal end of the colon, the proximal end of the large intestine. Well, inflammation in the colon can actually backwash onto the surface of the appendiceal mucosa. And so the patient may have a lot of abdominal pain. They may decide, like I said, they have a low threshold to get an appendix out so the patients don't get septic. They may find that this just has mucosal inflammation. So this patient may have colitis, and that could be infectious. It could potentially be something like even inflammatory bowel disease that's backwashing into the appendix. We can't tell exactly what that is from this specimen, but we can say, hey, this is not appendicitis. Something else might be going on. Keep an eye on this patient, see what they do. So there's other patterns we can see in the appendix that are not appendicitis that are important to know about, and here's one of them. Does anybody know what we're seeing here? So we're seeing the muscular wall, the mucosa, here's the lumen, but there's something more than just germinal centers here. There's these round oval aggregates of epithelioid cells with long, plump nuclei. And you can see that they're in the mucosa, and you can see even in the in the subserosa, you can see some of those lymphoid aggregates that occasionally contain similar aggregates of those epithelioid cells. Anybody in the chat know what we're looking at here? This is probably the best example of it here. You can see that how different this looks from a germinal center, right? So you don't have appendicitis here, you don't have neutrophils, but you have these lymphoid aggregates that also come with aggregates of histiocytes. And these aggregates of histiocytes are forming nice little balls, and they look kind of epithelioid. So those are granulomas. So this is granulomatous appendicitis. Why would you have granulomas in the appendix? Well, there's a couple of reasons for this. If you are studying for an exam and you're looking at buzzwords, you might see something like Yersinia, right? This is something that could be associated with rare infections, but actually more often, this could be a manifestation of Crohn's disease. It could also be chronic granulomatous disease. These are non-caseating granulomas. But probably the most common thing that this would be, if you found this in a kid, is that this would be chronic. Granulomatous and appendicitis would most commonly be associated with Crohn's disease. If these granulomas were caseating, you might think about fungus or acid-fast organisms, but these are non-caseating granulomas. So most likely, this patient actually might have Crohn's disease. So that's going to require some workup to figure out what's actually going on. All right, so let's talk about some more surprises. And hopefully this one's not going to be a surprise when you find it, but this is a really striking pattern. So here's an appendix that got removed, and you see there's no neutrophils, there's no inflammation really here, maybe just a few of them. Okay, here, I'll take it back. Here's a little micro abscess. There's really minimal inflammation in this appendix. There's really nothing in the muscular wall in terms of inflammation. All this looks pretty normal. But if you go back to low power here, what is all this stuff? You get these layers of really thickly dense eosinophilic material. And as you get closer to the glands in the mucosa, you can see that it looks like this stuff is just, mucus is just spilling out of these glands into the lumen. Anybody in the chat have an idea what this is? So hopefully when you find this, this is not a surprise, because hopefully somebody knows about this. But this histology is very, very typical of what you find in patients that have cystic fibrosis. The mucus they make, because they have an abnormality in the chloride transporter, the mucus they make is incredibly thick. And that thick mucus is just going to congregate and make this concretion in the appendix sometimes in these patients. So they may have pain and symptoms because their appendix is dilated by this mass of very thick mucus. But usually these patients are clinically known to have cystic fibrosis, but this is a very, very typical appearance. You can even see this in mucosal biopsies of this thick, thick mucus that just seems to be streaming out of these pits, of these crypts in the mucosa. All right, here's another surprise. Sometimes we find this in appendix. And you might find this with or without appendicitis. You always want to pay close attention to everything here. You want to take a very systematic approach when you're looking at an appendix. You want to look what's in the lumen, you want to look at what's in the mucosa, and you want to look at the muscular wall and the subserosa. And so as we look at this, we can see that there's some inflammatory debris in the lumen. Not a lot else going on. But wait, what's this? That doesn't look like any normal structure that we've seen yet as we've looked at these appendices. Does anybody in the chat know what we're looking at here? So you can see there's several layers to this structure. It has this little spine. It has a cuticle. It has some other internal structures, and then it has this little lumen here that looks a little bit like epithelial cells arranged around a tiny little lumen. Anybody know what this is? Let's look at another example of this and see some more of those structures. So here you can actually see both lateral spines here. And this is Enterobius. This is a pinworm. So you can have pinworms that get into the appendix, and these patients can have pain, and they may end up getting their appendix out. And this actually may be how you find out the patient has pinworms. So the treatment for this obviously is going to be a little different than your standard treatment for appendicitis, because their abdominal pain is probably related to the worm. So these worms are really distinctive because they have these lateral spines, and they have an intestine right here. Yeah, that's Enterobius vermicularis. Yep. So they're very distinctive. You got to be looking carefully because, like I said, you can find them in any layers. You have to examine all the layers. This one was in the lumen. The last one we looked at, this has actually made its way kind of into the wall. It's kind of creepy to think about that it's burrowed itself into the wall and it's hanging out in the submucosa. All right, and the last thing, so I talked early in this presentation about why we ink the base of the appendix, and this is why, because in as many as 1% of pediatric appendectomies, you're going to find this, and this is not appendicitis. So the lumen here is obliterated. Grossly, this is going to look like a yellow nodule. And so anything that looks solid in the appendix stands out. You're going to want to take a section of it, because this might be this. And so this yellow nodule, what you see is you've got nests of cells with this really finely stippled chromatin, kind of salt and pepper looking chromatin. And then you've also got smaller cords and individual cells and small groups of these similar cells that are going all the way through the muscular wall and even into the subserosa. Anybody know what this is? So this is the reason that we ink the base margin. We actually also ink the mesoappendiceal margin. So there's along the side of the appendix, there's soft tissue, the mesoappendix, the mesentery, and that can be a margin. So anywhere that we have a margin, and here we've trimmed it off so you don't see the ink, but anywhere we have a margin that the surgeon cut, we're going to want to put ink on that appendectomy specimen. Yeah, this is a well-differentiated neuroendocrine tumor. Very good. You've even got the correct terminology. These used to be called carcinoids, but the current term is well-differentiated neuroendocrine tumor. And so you want to know the margin status for this, because and go look at the most recent edition of the AJCC for the really detailed staging information about these, because it changed a little bit. And so the most important thing to know about these, particularly in kids, is the margin status, because if they don't get to that ink at the base margin, the surgeons are probably not going to do anything else for this kid. That kid is cured, this tumor is gone, they're not going to do anything else. Now, if this tumor did get to the margin, if it did get to the inked mesoappendiceal margin or the inked base margin, that's when the surgeons would go back and they would actually do an ileocecectomy to make sure they get all of this out. Otherwise, these kids don't need chemotherapy or anything wild. These very, 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 very rarely metastasize or anything bad. You just got to make sure you get it all out. And so, at most, they're probably going to get an ileocecectomy if the margin is positive. But that's definitely why you ink these. Well, these are some great examples of everything from what a normal appendix looks like to surprises we can get with mucus that looks funny, or worms, or neuroendocrine tumors. Really glad you joined me for this. Look forward to doing something again like this in the future. Thanks for being here.